All right, well, we'll go ahead and get started. Um, I want to welcome you to this afternoon's session yet again. My name is Gail Kwame, and I am in Augusta, Georgia at the Robert B. Greenblatt Library at Augusta University. And today's session is called Innovation and Needs-Based Program Paves the Way to Health Equity. So this program dealt with people who were incarcerated, and I decided to provide some definitions at the beginning of the session today, thinking that some of the attendees may not have worked with this audience in the past and may not be as familiar with this audience. So I thought I would level the playing field and make sure that people are comfortable with some of the terminology before we get started. So there is a difference between jails and prisons, for those of you who may not know that. Jails tend to be shorter term facilities that are usually administered at the local level, counties or cities. And the inmates who are there usually have a sentence of less than 1 year and are often held pending a trial, awaiting sentencing, or awaiting transfer to another facility. Prisons, on the other hand, are longer term facilities owned by a state or by the federal government and typically hold felons with sentences of more than a year. Some more definitions. An inmate is somebody who is in custody of an institution who is held involuntarily through operation of law enforcement authorities. And if someone is incarcerated, they are serving a term either in prison or in jail. The term justice involved is a broader scope term that covers anyone who is currently or has been involved with the criminal justice system. That includes jail, prison, pre-release, community supervision, pre-trial, promotion, or parole. And then we like to use the term returning citizens for people who are being released back into the community. This helps to remove the stigma of labels like ex-con, ex-offender, criminal, thug, and hopefully helps minimize the impact of using those labels for people that are returning citizens, returning to their communities. Some statistics here, and a lot of these numbers come from the Bureau of Justice Statistics. Our criminal justice system holds about 2 million people, over 1,700 in state prisons, or I'm sorry, there are over 1,700 state prisons, just over 100 federal prisons, 1,700 and some juvenile corrections facilities, well over 3,000 local jails, and there are also Indian country jails because many tribes are sovereign entities and have their own criminal justice systems. And these numbers do not include military prisons or immigration detention facilities. So about 9 million people are cycling through local jails every year. This number has actually gone down in the last couple of years, partly due to COVID. You may have seen in the news that lesser offenders were being released early from their sentences because COVID was running rampant in corrections facilities. And so they were trying to alleviate some of that by releasing people back into the community or into alternate living situations prior to their sentence being completed. So about 1 in 40 adults are under some form of correctional supervision. And again, that's that full spectrum that we looked at when we were talking about the concept of justice involved. But what a lot of people don't realize is that 95% of prisoners will be released at some point and return to the community. So the goal of programs like the one we're going to talk about today is to equip people to go out into the community better than when they came in, better prepared to be participating citizens when they return to the community. Unfortunately, there is a high level of recidivism, and you can see from this particular study that's mentioned here that over 60% of state prisoners are arrested again within 3 years of release. That number goes higher as time marches on, with up to 83% within 9 years of release being rearrested. And this population, and this is why we're talking today, is a very high health disparities population. And again, just so we have a common understanding of what a health disparity population is, it means there's a significant disparity in the overall rate of disease incidence, prevalence, morbidity, mortality, and survival rate in the diverse disparity population as compared to the health status of the general population. So here are some pretty staggering numbers about incarcerated populations. If we're looking at chronic health conditions, the justice-involved population, about 80 to 90% of them suffer from chronic health conditions, as compared to 50% in the general population. The substance use disorder number is very high as compared to the general population at 9%, compared to 65 to 85%. Similarly, mental illness, 63 to 76% of the justice involved, as compared to 18% of the general population. Co-occurring mental illness and substance use disorder, about 45% of justice involved, compared to 4% of the general population. And the next line you see in this table, there's newer research going on about trauma and adverse childhood experiences. And these are very staggering numbers. You can see 70 to 95% of the justice involved population has suffered from past trauma or adult adverse childhood experiences, compared to 12%, and then suffer additional trauma from being incarcerated. So this is a big area of concern. Looking at educational attainment, we're looking at high school diploma or GED. About 40% of the justice involved have attained that, as compared to 84% of the general population. So that's a reverse statistic from the other ones we've been looking at. Similarly, health insurance coverage, only 10 to 20% of the justice involved have health insurance coverage, compared to 80 to 90% of the general population. That has been alleviated a bit by the Affordable Care Act, where incarcerated people were allowed to sign up for health insurance, which is a newer perspective. So it'll be interesting to see how this number might change over time. And the last thing you see in this table is the risk of death from suicide or drug overdose is 10 to 40 times that of the general population. So certainly a health disparities population from multiple angles. There's higher rates. These are some of the diseases that were not mentioned specifically on the previous slide. So we're looking at HIV, hepatitis C, tuberculosis, diabetes, asthma, and high blood pressure. There was a study done that discovered that the justice involved die at 12 times the rate of the general population soon after release. We mentioned the mental health and substance use disorders, higher in the justice involved than even in other vulnerable high-risk populations. And some of these numbers are attributable to limited health literacy, lack of access to healthcare services, and difficulty navigating the healthcare system. So we mentioned some of the chronic health conditions that are encountered in the incarcerated. And this information informed what you'll see shortly in terms of the things we chose to focus on in the project that I'll be describing. So what can be done about this? Well, I'm going to describe a program where we used tablet computers to provide health education information to incarcerated folks. And the project I'll be describing is modeled after a small project that was done at one county detention center in Bozeman, Montana. And for that project, we brought in subject experts about these chronic conditions that affect incarcerated persons, put together a series of modules of health education about those topics. And there was a computer lab in that detention center. It did not have internet access, and that's a big challenge in working with the incarcerated, is that they often do not have full internet access. So we built what's called Internet in a Box system, which emulated searching the web, so that they would know what it was like once they were in a situation where they could access the internet once they were released, and provided health information in that way, along with some other modules that were uploaded onto the computer. And then there was a Vista volunteer involved with that project who helped do in-person training sessions. But that was only at one facility, very hard to replicate and very hard to have the time to do it multiple times. And there were some challenges about doing it that way. So we built on that project, however, and it informed this grant. So my project team and I applied for a grant from the National Library of Medicine, which is part of the National Institutes of Health, and they offer information resource grant to reduce health disparities. And the idea of this is to develop projects that bring useful and usable health information to health disparities populations and the healthcare providers who care for them. And the projects are meant to exploit the capabilities of computer and information technology and health sciences libraries to bring health-related information to these healthcare consumers and their providers. So the grant absolutely required that a librarian be involved, which was, music to my ears as a librarian. And I was really happy to be able to participate in this funded project. Um, there were 4 aims of our study. So the first was to conduct a needs assessment to determine the special health information needs and health coverage eligibility of justice-involved individuals preparing for reentry. The second aim was to deliver the health information curricula and training modules to justice-involved individuals currently incarcerated at partner sites to ADOVO, and I'll mention, I'll tell you what ADOVO is in just a moment. The third aim was to then measure the impact that that training had on the level of health literacy, confidence to improve healthcare management, and interactions with healthcare providers. And then the fourth aim was to follow a sample of justice-involved individuals for 6 months after they were released from incarceration. And we collected some post-release outcomes from that group. So Adovo is a mission-driven company based in Chicago, Illinois, that has developed these tablets to be deployed in corrections facilities throughout the United States. And ADOVO stands for Education Over Obstacles. And they are very interested in providing educational content. And it covers a spectrum of topics, anywhere from job preparation, GED. There's a lot of health and wellness topics on these tablets. Mindfulness training, anger management, any number of topics that you can think of. And for every hour of educational content that is accessed, the participants can then access an equal amount of time of entertainment content. So there's television shows, movies, and music also downloaded onto the tablets. And each user gets a unique login. So there's a way to track the usage of the tablets by specific individuals. And there's also a messaging system built into the tablets that we leveraged quite a bit for this project. So you can see on this screen here, there are a series of screens, and our project was called Improving Your Health Knowledge. It was set up as what's called a goal in the ADOVO system, which is a group of classes. So that's why we did it that way, because we had several modules of information to provide. And then there's a way for folks to track their usage, and there are certificates of completion available for a lot of the different courses that are available. And you can see on the screen with the red circle on it some of the other topics that were also available, like taxes and cell membrane biology. So again, there's quite a suite of topics involved. So based on what we knew of the chronic and other conditions encountered by people who are incarcerated, as well as some of the results from our needs assessment, we came up with a total of 12 themes under which these different education modules fell. So one of the goals of this project was to help people improve their self-advocacy and self-care skills when they're encountering a healthcare professional. So we had several modules under that topic. And pain management was a topic we had not considered, but came to the top from the needs assessment. So we did develop a module for that. And in the pilot project I mentioned in Bozeman, Montana, all of the participants were male. And in the corrections facilities participating in this project, there were female inmates at some of the facilities, and they specifically were asking for sexual and reproductive health topics. So that is what informed how we chose the overarching themes. And almost all of the information was provided by short video. Because of health literacy issues, we figured that was the most user-friendly way to go about providing this information. So I mentioned the needs assessment that was administered in February of 2018. And that was at all partner facilities with Edovo. And at the time, there was, well over 100 facilities. And we were very pleased with the results. We got over 1,800 responses to that needs assessment. Then we did our research study, also deployed via the tablets, but at this point there were 10 participant corrections facilities where the tablets were already in place. And this phase of
Oh, Gail, you're muted.
there we go. Oh, sorry. Thank you. This was administered between February 2019 and February 2020. So we had memoranda of understanding with those corrections facilities. They were on board with it. And Adovo in the background of Chicago was able to push out messaging to just the people at those facilities, announcing the study, reminding people once they had gotten in and signed up for the study, if they wanted to go back in and complete some more of the modules and that kind of thing. Probably one of the biggest bugaboos with this project was how to get participants to consent. We had to go through, of course, IRB approval for human subjects for this project. And in working with the incarcerated, it's even more complex to get IRB approval because they're considered a vulnerable population. And we decided that, again, we wanted to provide multiple formats in which to provide the consent. And so we did create a video, and we also had a PDF document linked in the tablet. And in order for them to be eligible to participate, they had to be at least 18 years old and had to have at least 21 and no more than 180 days remaining on their sentence. And we worked with our IRB to see if there was any way we could cut down some of the verbiage on the video from the consent language. And unfortunately, the answer was no. And so it's the most gripping 8-minute video you can imagine of study consent language. But it was, I think that we did well to provide multiple formats for people. I mentioned that these modules were grouped as a goal within the EDOVO system. We developed pre and post intervention questionnaires. Those were also administered on the tablets. I mentioned the messaging system, so we were able to send reminder messages out to people who had accessed the content but hadn't necessarily completed all phases of the study. So they consented, did the pre-questionnaire, took some of the classes, and then there was a post questionnaire. And participation was incentivized with increments up to $50 loaded onto CLIN cards, which are like little credit cards at different stages of the study. And that is the bulk of the language, and that consent that I was talking about was all of the caveats about using those CLIN cards. And then we also provided contact information for project partners and project researchers that were distributed to facilitate that post-release follow-up phase of the study. That also presented a challenge. So we ended up printing up postcards that we sent out to the different corrections facilities that were given out. But as people are exiting back into the community, there's so much going on. It's kind of a flurry of activity. So I think we lost a lot of potential post-release participants because of that dynamic. Data about which modules were being accessed was collected, and we got data dashboards from EDOVO every week in an email. And then all of that raw data was being collected and managed at EDOVO. So hopefully you're reading between the lines. Some of the grant money went to EDOVO for the work that they were doing with us. And then we got that raw data at the end of the study, came back to the research team, and we had data specialists that were doing analysis of it. So in terms of what was in these questionnaires, we had 3 sets of questions. The first section was about measuring health literacy, and some of those questions came from the newest vital sign. Some of you may be familiar with that instrument, along with some that we had used for that previous study I mentioned in Montana. We also had a list of questions about, a scale talking about the importance of different health behaviors. And then the third set of questions asking about confidence in performing selected health-related behaviors. So I didn't want to blind you with science and put a bunch of graphs on these slides. So I'm just giving you kind of higher level data information. So over 3,000 individuals at these 10 different facilities altogether accessed at least one of our educational modules. And I should mention that these modules were made available across the board, even if somebody did not want to participate in the study. So if people did not want to consent to participate in the study, they could still get at the content. And to this day, our content is now on all of the tablets across the board in all of the EDOVO facilities. 453 individuals completed the introductory material and the consent. And of those 453, 112 completed all phases of the study. No questions were mandatory to answer. Every question was optional. So the data that you'll see next is from those 112 participants. And then we had 9 total people who completed the post-release survey. So again, it was a challenge to try to incorporate that post-release phase. And my co-PI and I have said if we were to try to do something like this again, we probably would deal with that audience differently. It was very challenging. So from the demographic side of things, the majority of our participants were male, but there was a mixture of corrections facilities, and the majority of the folks who were incarcerated were male. So that's not a big surprise. A majority of the participants were white. 46% had completed high school, followed by some participants who had completed some college. The majority were between 35 and 44 years old, and the second highest were between 25 and 24. So really the majority age span from 25 to 44 years. So there was statistically significant overall improvement in all three areas of the study from pre-test to post-test. So the aggregate results in each of those three areas I mentioned. The health literacy section, there was statistically significant improvement in 3 of 7 of those questions. In terms of the health behaviors, there was improvement in all 9 of those questions. And in the confidence area, improvement in all but 1 of the questions in that area. So we were very pleased with these results. We did get some correspondence because we provided contact information to the participants. So it was kind of interesting to get letters from a couple of the participants. The more wordy letter was really kind of heartwarming to me because he is he's serving several life sentences. He's never going to be released, but he says that even if he's never going to be released, it doesn't mean he doesn't want to improve himself, and maybe he can pass the knowledge on to others. So we really appreciated getting this correspondence. So just a couple high-level conclusions that providing these kinds of modules paired with self-directed learning on tablet computers is indeed an effective method for improving health literacy and self-care management for incarcerated persons. And we found the findings of this study was there was really not a strong correlation between gender, race, or education level and health literacy or self-care management, just based on the findings of this particular study. So Brian, I can't see the Q&A. Is there anybody that's put any questions in at this point?
Stand by. No.
Okay, so I will tell people if you'd like to ask a question, please go ahead and type it in the Q&A and we'll catch up with it. And I'll be happy to answer. I do have a few more slides though. So I was asked to share, what might this mean for people who might want to work with this audience or other similar vulnerable audiences or wanting to work with tablets. So first of all, know that Edovo is not the only provider of tablets for corrections facilities, and you need to do some legwork to decide which company might work best for your needs. I mentioned that Edovo's mission is to provide educational content, not just entertainment content. And some of the other tablet providers are primarily entertainment content. I will say that they're finding that the corrections facilities that use these tablets have found a reduction in, violent interactions between the inmates and that kind of thing. So there is a benefit to using these, but we really, we're interested in providing educational content, and the financial framework for each of these companies is a little different, and the funding sources. So it's worth doing some exploration about that. We also ran into a speed bump, and it was kind of disappointing in that we have a transition center blocks away from my university here in Augusta, Georgia, for people who are 6 months away from being released into the community. So they have work released during the day, and then they stay at this transition center, overnight and what have you. And we really wanted to incorporate them into this project because it would have been a beautiful combination research, study, and service project for that facility. Well, they fall under the auspices of the State Department of Corrections, as opposed to at the county or city level. And we learned that the State Department of Corrections already had a contract in place with another tablet provider. And they felt like it would be looking like we were showing favoritism to Adovo if we used them for this one project, and we would have had to get a waiver, and the lawyers got involved, and we unfortunately kind of backpedaled away and said we're sorry, but it's not gonna work. But fortunately, Adovo, had other facilities that were very interested in participating. I mentioned the IRB process being more complex, so you really need to allow a lot of front end time to go through that process when you're working with justice involved participants. And I also mentioned some of the challenges about the consent process. So I see there's some questions in the Q&A, so let me take a look at that. There's a question about how would we do the post survey, meaning the post release survey, I'm guessing, differently. I think that we would probably not do it at all or do a separate study and leverage the probation officers in whatever communities that we might want to work with. My co-PI has done other research projects with justice involved and has gone through probation officers to do that kind of work in working with people who have already been released. So I think that's probably the better solution. Thank you for that question. Another question, are there plans to do a similar study with incarcerated women, specifically incarcerated women, I'm guessing? We don't have plans to do that right now. That's not to say it couldn't be done. I think that would be very interesting to do a comparison between those two audiences. But right now, we don't have plans. You're welcome to build on our project and do that. If you're interested in that, I'd be happy to talk with you. Another question. Regarding the disclaimer language, what sort of pushback did you get when you attempted to simplify it? Okay, so you're asking about the IRB said, no, you can't remove any of that language. So we weren't really trying to simplify the language. We were trying to remove some of the language about the CLIN cards specifically, because it was just, verbose about, if you go to an ATM, then they're going to take so much out of your money and you can't use the card for this, but you can use the card for that. And it was very onerous. And so we were inquiring as to whether we could cut some of that out. And unfortunately, the answer from our institutional review board was no, that language all had to be included. So that's what I'm seeing in the Q&A. So Brian, I don't know if you have a way to push the button to say I've answered those so far.
You've answered all of these.
Okay, and then I have one more. Where can we have access to the surveys and the questions used? My email is on the last slide, and I'm happy to share that with you. We do have a manuscript in press in the Journal of Correctional Healthcare, and I can't remember if those instruments are going to be appended to that, but yeah, we're happy to share that with you. So please feel free to email me. And then I see there's something in chat. Is that something? Why is the IRB process more complex? That is because, as I mentioned earlier, people who are incarcerated are considered a vulnerable population. They're, literally a captive audience, and they're in a very special situation. You also have to be very careful about how you incentivize a study with people who are incarcerated. So there's just kind of some layers of complexity there. All right, let's get on to, I think I have a couple more slides here. Some other things to think about. You just want to make sure you have complete buy-in from your participating facilities. Make sure you get letters of support and memoranda of understanding, so everybody understands what's happening. Everybody understands the scope of the project and what you're going to be doing. That's very important. We were fortunate in that a lot of the facilities participating in this had a pre-existing relationship with Edovo and with the tablet system. So already kind of understood the model and how it was a benefit. So we didn't have to kind of quote unquote sell it to those particular facilities, but we did get letters of support and memoranda of understanding from all of them. And then I mentioned some of the challenges about kind of tracking people once they're released. They may not have a phone right away. So it's awkward to try to stay in touch over that, that 6-month window where we were trying to, hear from them. What we did was we put a certain amount of money onto that CLIN card if they gave us their contact information upon release. And then a few months later, if they contacted us again, we put a little more money on there. And then we put the remaining balance on there if they did the follow-up study 6 months after release. So that was the incentive to stay in touch with us. But they're trying to find housing, they're trying to find a job, they're reintegrating into the community, getting reacquainted with family. There's all kinds of things going on during this time in their lives. And so it's high stress as it is. But we got phone calls from a couple of people. We provided phone number, and then as I showed, we got some physical correspondence as well. So I'm certainly open to other questions. We're finishing a little bit early. That's always the gift of time, and I'm happy to take any other questions. And I'm going to put up my very last slide because I said my email is on there. I'd be happy to take email from people as well. All right, well, seeing no more questions in the Q&A, I want to thank you for your participation. Oh, I see one more in the chat. Oh, thank you, you're welcome. And, again, please feel free to contact me if you have questions or if you'd like to see the research instruments. I'm happy to share those with you as well. Have a great afternoon.